Hello everyone. So today we'll be discussing the topic neoplasia. First of all, what is a neoplasm? Neoplasm is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated, and it persists in the same excessive manner even after the cessation of the stimulus that evoked the change. Now there are two components of neoplasm, the parenchyma and the stroma. The parenchyma comprises of proliferating tumor cells and it determines the nature and evolution of tumors. The next component is the stroma. The stroma is composed of fibrous connective tissue and blood vessels. It provides the framework on which parenchymal tissue cells grow. There is another term known as desmoplasia. Desmoplasia is the production of abundant collagenous stroma by parenchymal cells. It leads to excessive fibrosis in tumors. For example, squamous carcinoma of breast. Now the nomenclature of neoplasia. It depends on the type of tumor. For example, all the benign tumors end with the word "oma". For example, adenoma, papilloma, and fibroma. There are a few exceptions to this rule. There are 5 tumors which end with the word "oma", but they are not benign, they are malignant. These are melanoma, seminoma, hepatoma, lymphoma, and mesothelioma. Now, malignant tumors which are of mesenchymal origin are called sarcoma, and those of epithelial origin are called carcinoma. What are mixed tumors? When two types of tumors are combined in the same tumor, then that tumor is known as a mixed tumor. For example, adenosquamous carcinoma and carcinosarcoma. One more example, which is the most important, is teratoma. Teratoma is a mixture from all the three germ cell layers, that is ectoderm, endoderm, and mesoderm. It originates from totipotent germ cells normally found in ovary and testes. Teratoma contains bone, epithelium, hair, tooth, muscle, fat, and even nerves. For example, ovarian cystic teratoma. Now there are two tumors which are not actual tumors. These are hematoma and choriostoma. Hematoma is the abnormal tissue at a normal site, and choriostoma is the normal tissue at abnormal site. Example of hematoma is lung, hematoma of lung. It consists of mature cartilage, mature smooth muscle, and epithelium. And example of choriostoma is thyroid gland, which is present on the tongue, and pancreatic tissue in mucosa of small intestine. Now we come to characteristics of tumors. There are 5 characteristics which can be used to differentiate between benign and malignant tumors. The first one is the rate of growth. In case of malignant tumors, the rate of growth is very fast because of high mitotic rate and less doubling time, and also slower death rate. In case of benign tumors, the rate of growth is slow. Clinical features which are characteristic of malignant tumors are weight loss, anorexia, and anemia. Now, gross features of malignant tumors are the shape of malignant tumors is irregular, they are poorly circumscribed, and they extend into the adjacent tissues. They invade the adjacent tissues. Sarcoma has fish flesh-like consistency, and carcinoma is very firm. Benign tumors are spherical or ovoid. They may be encapsulated and they are well circumscribed. They are freely movable in the surrounding tissue and they compress the adjacent tissues. Now the microscopic features. The microscopic features can be defined by two terms. The first one is differentiation and the second is anaplasia. In case of malignant tumors, there is lack of differentiation and presence of anaplasia. What is differentiation? Differentiation is the extent of morphological and functional resemblance of tumor cells to corresponding normal cells. There are four categories of differentiation, well-differentiated tissues. They resemble tumor cells highly. The resemblance of tumor cells to normal cells is very high. And in case of moderately differentiated cells or tissues, the resemblance is moderate. In case of poorly differentiated, the resemblance is sort of low. And in case of undifferentiated tumors, there is no resemblance to normal cells. Anaplasia is actually the lack of differentiation. It is a hallmark of malignant transformation. It is an irreversible process. There are 10 features which define anaplasia, which are loss of basal polarity, pleomorphism, nucleus to cytoplasmic ratio, anisonucleosis, hyperchromatism, nucleolar changes, mitotic figures, tumor giant cells, DNA aneuploidy, and cytoplasm increased mucin. These are only found in case of malignant tumors. Loss of basal polarity means that the nuclei always lie away from the basement membrane. Pleomorphism is the variation in shape and size of the cells. Nucleus to cytoplasmic ratio is increased, and it becomes 1:1. In case of normal cells, the nucleus to cytoplasmic ratio is 1:4 or 1:6. Anisonucleosis means that nuclei show variation in shape and size. Hyperchromatism is due to increased nuclear material or DNA, responsible for dark staining of cells. Nucleolar changes. Nucleolar changes include nuclei becoming more prominent, okay, and mitotic figures are present due to increased mitosis. Tumor giant cells are only present in case of malignant tumors. Okay. Now spread. The spread of malignant tumors is of two types, metastasis and local invasion. These two types of spread is only seen in case of malignant tumors and not in case of benign tumors. What is metastasis? Spread of tumor to other parts because of penetration into blood vessels, lymphatics, and body cavities. There are three routes of metastasis: lymphatic spread, hematogenous spread, and direct seeding of body cavities or surfaces. Lymphatic spread is a characteristic feature of carcinoma. What is a sentinel lymph node? It is the first lymph node that receives lymph from primary tumor. Sentinel node mapping is useful in case of radiolabeled tracers and dyes. Examples of lymphatic spread are carcinoma of breast and carcinoma of lung. There are two forms of lymphatic spread: lymphatic permeation and lymphatic emboli. When walls of lymphatics are readily invaded by cancer cells and may form continuous growth in lymphatic channels, then it is the lymphatic permeation. And if the malignant cells detach from emboli and they are carried along the lymph, the tumor emboli are lodged in subcapsular sinus where they start growing, which means that the whole lymph node is replaced by metastatic tumor. This is the lymphatic emboli form. The second route of metastasis is hematogenous spread, and it is a characteristic of sarcoma. Venous invasion. It occurs by venous invasions. Veins are more preferred than arteries because they have thin walls. Liver and lungs are the most commonly affected organs. All portal area drainage flows to liver and all caval blood flows to lungs. Example is renal cell carcinoma, also hepatocellular carcinoma. Now the third route is the direct seeding of body cavities or surfaces. Body cavities which lack physical barrier, for example peritoneal cavities, are involved in this type of spread. Other cavities are pleural, pericardial, subarachnoid, and also joint spaces. Now, a very typical example is pseudomyxoma peritonei, in which the mucus secreting appendical carcinoma or ovarian carcinoma fill peritoneal cavity with gelatinous neoplastic mass. And it can also spread via CSF and implantation because of surgeon's scalpel, needle sutures, and direct prolonged contact of cancer of lower lip cavity implants to upper lip. Now, what is the metastatic cascade? Sequential steps involved in hematogenous spread of the tumor is known as the metastatic cascade. There are in total 8 steps. We will see all the steps one by one. First of all, it is the clonal proliferation and angiogenesis. Development of rapidly proliferating clone of cancer cells. Tumor heterogeneity. Population of monoclonal tumor cells. A clone or subpopulation is involved in the development of metastasis. Second step is tumor cell loosening. Normal cells are glued to CAMs due to CAMs. What are CAMs? CAMs are cell adhesion molecules. For example, E-cadherin. In the case of cancer, there is loss or inactivation of E-cadherin and CAMs. E-cadherin expression is silenced by EMT, epithelial mesenchymal transition. EMT is controlled by twist and snail transcription factors. Mutation in gene encoding for E-cadherin is associated with gastric carcinoma. Very important. Now the third step is tumor cell and ECM interaction. Tumor cell and ECM interaction. Loosened tumor cells are attached to ECM protein, laminin, fibronectin, vitronectin, and collagen. This process is facilitated by receptors on the cancer cells. Loss of integrins and transmembrane receptors are also the factors which contribute to this step. The next step is degradation of ECM. Tumor cells overexpress proteases and matrix degrading enzymes. These are metalloproteinases, MMPs, for example, collagenases and gelatinases. Inhibitors of metalloproteins are decreased. These enzymes bring about dissolution of ECM. First, the basement membrane of tumor is dissolved, then through interstitial matrix of tumor cells. Finally, they dissolve the basement membrane of vessel wall. The fifth step is the entry of tumor cells into capillary lumen. AMF or autocrine motility factor is a cytokine derived from tumor cells which stimulates receptor-mediated motility of tumor cells. Thrombus formation. Tumor cells form thrombus. It provides nourishment to tumor cells and also protects them from immune attacks by circulating host cells. Extravasation of tumor cells. Tumor cells attach to vascular epithelium extravasate to extravascular spaces. Survival and growth of metastatic deposits. Extravasated malignant cells lodge in bright environment. This promotes further growth under the influence of growth factors produced by tumors. So in this diagram, we can appreciate all the steps: clonal expansion, growth, diversification, angiogenesis, that is the formation of new vessels, metastatic subclone, adhesion to an invasion of basement membrane, passage through extracellular matrix, intravasation into blood vessels, interaction with host lymphoid cells, formation of tumor cell embolus, adhesion to the basement membrane, extravasation, metastatic deposit, angiogenesis, and finally. So now we will discuss about the molecular basis of cancer. Four regulatory gene classes are responsible for normal cell growth. These are proto-oncogenes, tumor suppressor genes, apoptosis regulating genes, and DNA repair genes. Proto-oncogenes are the normal growth promoting genes. Tumor suppressor genes are growth inhibiting genes. Apoptosis regulating genes control programmed cell death. And DNA repair genes control damage to proto-oncogenes and anti-oncogenes. We will discuss about each one of them in detail. Now, what are proto-oncogenes? Normal genes required for cell proliferation. They act under physiological stimuli, for example, growth factors. Without the physiological stimuli, they are silenced. Oncogenes are derived from mutation of proto-oncogenes. When proto-oncogenes, due to mutation, become autonomous, that is, promote cell growth without any physiological stimuli, they are called oncogenes. Oncogenes are present in cancer cells, and oncoproteins are the proteins lacking regulatory control. Now, proto-oncogenes are further classified into five classes. These are growth factors, growth factor receptors, proteins involved in signal transduction, nuclear regulatory proteins, and cell cycle regulators. Growth factors. Growth factors include several proteins, for example, PDGF beta, TGF alpha, and also fibroblast growth factor, c-MET, and HGF. Growth factor receptors are EGF receptor, c-KIT receptor, and FMS-like receptors. Proteins involved in signal transduction are RAS, this is very important, and ABL-BCR. RAS is of three types: KRAS, NRAS, and HRAS. Nuclear regulatory proteins are MYC and NMYC. Cell cycle regulators consist of cyclin D, cyclin E, and CDK4. Now, what is the RAS gene? RAS protein is involved in signal transduction. It is a GTP binding protein. Point mutation of RAS family is the most common abnormality of proto-oncogenes in human tumors. Now, what is the normal scenario? In inactive state, RAS binds GTP. Inactive RAS binds GTP. Now, in the presence of growth factor and growth factor receptors, RAS becomes activated by exchanging GTP for GTP. This is active RAS. It has GTP. Now, this activated RAS recruits RAF1 and P13K. Active RAS recruits RAF and P13K. Now, further mitosis occurs and GTP is activating protein known as GAP. It breaks GTP into GTP. So, RAS is back to that inactive state. Now, in case of mutations, mutation in RAS gene, when mutation occurs in RAS gene, GAP stops working. GAP is not working now. So GTPase activity cannot be increased. No breakdown of GTP occurs. Therefore, there is permanent activation of RAS. Uncontrolled mitosis occurs, which leads to cancer. Now, the three types of RAS genes are KRAS, and KRAS is found in colon, lungs, and pancreatic tumors. And NRAS is found in melanoma and blood tumors, for example, AML. Third one is HRAS. It is found in bladder and kidney tumors. Now we will discuss about ABL-BCR protein. ABL is a proto-oncogene having tyrosine kinase activity. ABL gene is normally located on chromosome 9. This is ABL gene. It is located on chromosome 9. Okay. It is translocated to chromosome 22. 22 is the BCR locus. It fuses with the BCR gene and forms an ABL-BCR hybrid gene. It is also known as Philadelphia chromosome. Philadelphia chromosome is the chromosome number 22. It has constitutive tyrosine kinase activity. Abnormal signal transduction occurs even without growth factors in chromosome number 22, which leads to uncontrolled mitosis and finally cancer. A typical example is chronic myeloid leukemia, CML. Now we will discuss MYC gene. MYC gene is normally located on chromosome 8. And the second gene, the IgG gene, is located on chromosome number 14. What happens in Burkitt lymphoma is the chromosomal translocation from chromosome number 8 to 14. MYC gene, which is normally located on chromosome 8, is translocated to chromosome number 14. It fuses with the Ig gene and forms a MYC-Ig hybrid gene. Hybrid has abnormal regulatory activity. It leads to uncontrolled mitosis and finally cancer. This cancer is Burkitt lymphoma. Now MYC genes are also of 3 types. c-MYC, it is involved in Burkitt lymphoma. N-MYC, involved in neuroblastoma. And L-MYC, which is involved in lung carcinoma, small cell carcinoma. Now we come to tumor suppressor genes. Tumor suppressor genes are the genes which apply brakes to cellular proliferation and regulate the cell cycle. They act by entering the cell into G0, which is the resting phase. Loss of function of tumor suppressor genes leads to uncontrolled cell proliferation and carcinogenesis. Mechanism of loss of function may be because of chromosomal deletion or due to point mutation. Examples of tumor suppressor genes are RB gene or the retinoblastoma gene and TP53 gene. Now retinoblastoma gene is found on chromosome number 13. It is the first tumor suppressor gene to be discovered. Now what happens is in the presence of growth inhibitors, for example TGF-beta and P53, there is activation of CDK inhibitors which inactivate cyclins and CDK5. There is hypophosphorylation of retinoblastoma gene. It becomes active in the hypophosphorylated state. It forms an inactive complex with transcription factor EF2 which blocks the cell cycle division. And there is no mitosis. But in case of mutation, there is permanent inactivation of retinoblastoma gene. Permanent dislocation of retinoblastoma from transcription factor EF2 occurs. There is abnormal cell division, mitosis, which leads to cancer. Now the thing to note is that the retinoblastoma gene in hypophosphorylated state is active and in hyperphosphorylated state it is inactive. In the active retinoblastoma gene, that is in the hypophosphorylated state, prevents the replication by forming an inactive complex with transcription factor EF2. This is an anti-proliferative effect. It blocks cell cycle division. It inhibits cell cycle at G1 to Gs phase. Inactive retinoblastoma gene, which is the hypophosphorylated form, causes its inactivation. Therefore, there is cell replication. Mutation in retinoblastoma gene leads to permanent inactivation of retinoblastoma. Now, function of retinoblastoma may be compromised in two ways: loss of function mutations involving both retinoblastoma alleles, or shift from active hypophosphorylated state to inactive hyperphosphorylated state, which is caused by increased CDK or cyclin D activity and decreased CDK inhibitors. What is retinoblastoma? It is associated with the concept of loss of heterozygosity and Knutson's two-hit hypothesis. Knutson's two-hit hypothesis says that two mutations or hits involving both alleles of retinoblastoma gene are required to produce retinoblastoma. Now there are two types of retinoblastoma: familial and sporadic. Familial comprises 40% of cases. It is bilateral. Somatic cells inherit one mutant retinoblastoma gene from a carrier parent, and the other mutation occurs after birth. Besides retinoblastoma, children inheriting mutant retinoblastoma gene are 20 times more susceptible to developing the risk of cancers, for example, osteosarcoma, breast, colon, and lung cancer. The other form, the sporadic retinoblastoma, constitutes 60% of the cases. It is unilateral. It is acquired because both the somatic mutations in the two alleles occur after birth. In case of familial cases, Knutson's two-hit hypothesis can be explained by the first genetic change. In this, the gene is inherited from an affected parent, and the second hit or the second mutation occurs in the postnatal life and both alleles are lost, as we can see here. This is the first hit and this is the second hit, which occurs after birth. In case of sporadic or non-hereditary, both the mutations first and the second hit occur postnatal. This is the first hit and this is the second hit. Both occur after birth. Now, loss of heterozygosity, which is the second principle explaining retinoblastoma, can be explained by in hereditary retinoblastoma or sporadic or familial retinoblastoma. Children are born with one normal and one abnormal retinoblastoma gene. That is, they are heterozygous for retinoblastoma gene. Mutations in normal retinoblastoma gene result in loss of heterozygosity. There is loss of heterozygosity. Okay, so now we come to P53 gene. It is a tumor suppressor gene plus a DNA repair gene. It is also known as the guardian of the genome or the molecular policeman. It is located on chromosome number 17. The pathogenesis can be explained by this diagram. When there is DNA damage due to UV radiation, ionizing radiation, carcinogens, mutagens, the normal cell is under hypoxic stress. P53 accumulates and binds to DNA. Transcription dependent and independent effects on target organs occurs. There is P53 induced activation of P21 and GADD45 activation or the activation of BAX and PUMA if the repair fails. BAX and PUMA are pro-apoptotic genes which are responsible for apoptosis if the repair fails. P21 is responsible for the arrest of the cell cycle at G1 phase, and both P21 and GAD44 DNA repair gene are responsible for successful repair of the DNA. Now, in case of mutations, P53 dependent genes are not activated. There is no cell cycle arrest, no DNA repair, no senescence. The mutant cells undergo expansion and additional mutations, which results in cancer, malignant tumor. Apoptosis regulating genes. These are of two types, pro-apoptotic genes and anti-apoptotic genes. Pro-apoptotic factors include BAG, BAGS, BID, and P53. Anti-apoptotic factors include BCL2, BCL-XL. In cancer cells, the function of apoptosis is interfered due to mutations in these genes. Mutation in apoptosis regulating genes leads to inactivation of pro-apoptotic factors or overactivation of anti-apoptotic factors. This leads to escape of cell death, uncontrolled growth, and finally cancer. The intrinsic apoptotic pathway is more frequently disabled in cancer. In follicular lymphoma, there is presence of translocation 14 to 18. It causes increased expression of BCL2, which prevents apoptosis, which induces cancer. Now, the most important DNA repair gene is P53. Defects in DNA repair may be of three types: nucleotide excision repair, mismatch repair, or recombination repair. Example of nucleotide excision repair is xeroderma pigmentosa. Mismatch repair is HNPCC, which is hereditary non-polyposis colorectal carcinoma. And recombination repair, Bloom syndrome, ataxia telangiectasia, and Fanconi anemia. Now, what is Warburg effect? It is a growth-promoting metabolic alteration. It can also be called aerobic glycolysis. Now, Otto Warburg observed that cancer cells had increased rates of glycolysis despite the availability of adequate oxygen levels. It is a distinctive form of cellular metabolism characterized by increased glucose uptake and increased conversion of glucose to lactose via glycolytic pathway seen in the presence of abundant oxygen. Now, why does this process occurs? Why oxidative phosphorylation does not occur? Oxidative phosphorylation yields 36 molecules of ATP per molecule of glucose, but it fails to produce any carbon moieties needed to build cellular component for growth, for example, protein, lipids, or nucleic acids. But in case of aerobic glycolysis, it generates only 2 ATPs, but it provides rapidly dividing turnover cells metabolic intermediates needed for synthesis of cellular components. Warburg metabolism is not cancer specific. It is seen in rapidly growing normal cells. Balance between oxidative phosphorylation and aerobic glycolysis is required for cellular maintenance. Now, what is oncometabolism? Some oncoproteins mutated, for example, mutated IDH. What is IDH? Isocyclate dehydrogenase. They act by causing the formation of increased levels of oncometabolites that alter the epigenome, leading to changes in gene expression that are oncogenic. Oncogenic IDH mutations include gliomas, AML, sarcomas, and cholangiocarcinomas. Mutated IDH causes the conversion of alpha ketoglutarate to 2-hydroglutarate, which is an oncometabolite. Now, what is angiogenesis? Angiogenesis is the process of formation of new vessels because of the growing tumor. It occurs to supply the newly formed tumor cells with sufficient nutrients and oxygen. They promote metastasis and stimulate the growth of tumor cells. Angiogenesis is controlled by balance between angiogenesis promoters and inhibitors. What is angiogenic switch? Angiogenic switch leads to local production of angiogenic factors or loss of angiogenic inhibitors. Driver mutations in TSG genes and oncogenes favor angiogenesis. P53 stimulates expression of anti-angiogenic molecule thrombospondin 1. Therefore, P53 represses the expression of angiogenesis. It represses the expression of pro-angiogenic molecule VGF, vascular endothelial growth factor. Gain of function mutations in RAS and MYC increase VGF. Proteases elaborated by tumor cells and stromal cells influence the balance between pro and anti-angiogenic factors. Some proteases release PFGF from ECM. Others release anti-angiogenic factors, which is angiostatin and endostatin. Okay. Now we will discuss about carcinogens and carcinogenesis. Carcinogenesis is the mechanism of induction of tumors, and carcinogens are the agents which can induce tumors. There are three types of carcinogens: chemical, physical, and biological. Chemical carcinogens may be direct acting or indirect acting. Direct acting chemical carcinogens are alkylating agents, for example, beta propiolactone, dimethyl sulfate, and anti-cancer drugs. They may be acylating agents, for example, acetyl imidazole. Now, indirectly acting chemical carcinogens are polycyclic and heterocyclic aromatic hydrocarbons, for example, benzopyrene and benzanthracene. Aromatic amines, amides, and azodies, for example, benzidine. Natural plant and microbial products, for example, aflatoxin B1, saffrole, and betel nut. Other indirect acting chemical carcinogens include insecticides, pesticides, amides, nickel, chromium, nitrosamine, and amide. Now, physical carcinogens may be of two types: radiation and non-radiation. Non-radiation include the physical injuries, and radiation include the UV light. UVB is the most important in causing cancer. UVA and UVC as such do not cause cancer. And the other category is the ionizing radiation, for example, X-rays, gamma rays, alpha rays, and beta rays. Biological carcinogens may be viral or bacterial. The viral may consist of DNA virus or RNA virus. The DNA virus involved are HBV, HPV, HHV8, and EBV. RNA viruses include HCV and HTLV1. Now, the bacterial biological carcinogens include H. pylori, which causes gastric adenocarcinoma, and gastric lymphoma, mild lymphoma, which is of B cell origin. Now, HBV, hepatitis B virus, is responsible for Burkitt lymphoma, nasopharyngeal carcinoma, T cell lymphoma, and a subset of Hodgkin's lymphoma and gastric carcinoma. Human papilloma virus may be of two types: HPV E6 and HPV E7. HPV-E6 is the low-risk HPV and it is responsible for benign squamous papilloma or warts. It stimulates TERT and inhibits p53 gene. HPV-E7 is the high-risk HPV and it is responsible for squamous cell carcinoma of cervix, anogenital region, head and neck. It inhibits both p21 and RB retinoblastoma E2F hybrid gene. Now we will discuss about the stages in carcinogenesis. There are three stages: initiation, promotion, and progression. In case of initiation, there is metabolic activation of procarcinogens. Now, this metabolic activation is required only by indirectly acting carcinogens. They required metabolic conversion within the body to become ultimate carcinogens. This step is not required by direct acting carcinogens. Now, reactive electrophiles. Direct acting carcinogens are intrinsically electrophiles, electron deficient, but indirect acting carcinogens become electron deficient after metabolic activation. That is, they become reactive electrophiles. After this step, both direct and indirect behave alike. Reactive electrophiles bind to electron-rich portions of DNA. Third step is the target molecule mutation. The primary target of electrophiles is DNA to produce mutagenesis. Any gene may be the target molecule. The most frequently affected proto-oncogene is the RAS gene, and the most frequently affected tumor suppressor gene is the p53 gene. What is the initiated cell? The unrepaired damage in DNA becomes permanent and fixed only if the altered cell undergoes at least one cycle of proliferation. This results in transferring change to next progeny of cells. Therefore, DNA damage becomes permanent and irreversible. The second step is the promotion. Promoter carcinogens do not damage DNA and thus are not mutagens. They enhance the effect of inhibitors. They cause clonal proliferation and expansion of initiated mutated cells. They do not produce any sudden change. Change may be irreversible. Progression. When mutated proliferated cells show phenotypic features of malignancy, this indicates there is progression through the process of chemical carcinogenesis. There is a test known as Amy's test, which now we will discuss about the clinical manifestations of cancer. The systemic manifestations include cancer cachexia, fever, tumor lysis syndrome, and paraneoplastic syndrome. Cancer cachexia is the hypercatabolic state defined by loss of muscle mass with or without fat loss. The mediators are TNF-alpha, IL-1, IL-8, and IL-6. They affect the skeletal muscles and adipose tissue. In the skeletal muscles, it leads to muscle wasting, lipolysis, and thermogenesis. In adipose tissue, it leads to browning and lipolysis. Tumor lysis syndrome is caused by extensive destruction of a large number of rapidly proliferating tumor cells. It is associated with Burkitt lymphoma, acute lymphoblastic leukemia, and chronic lymphoblastic leukemia. It is characterized by hyperuricemia, hyperkalemia, and hyperphosphatemia, and hypocalcemia. Paraneoplastic syndrome is a group of conditions developing in patients with advanced cancers, and these can neither be explained by direct and distant spread of tumor nor by release of hormones that are indigenous to the tumor cells of origin. It is a disease or a symptom that is a consequence of cancer, but not due to presence of local cancer cells. Various paraneoplastic syndromes include Cushing syndrome, hypercalcemia, acanthosis nigricans, DIC, migratory thrombophlebitis, hypertrophic osteoarthritis, myasthenia gravis, polymyopathy, encephalopathy, and peripheral neuropathies. The cancer which is associated with Cushing syndrome are small cell carcinoma of lung, carcinoid tumor, pancreatic tumors, medullary carcinoma of thyroid. Tumors associated with hypercalcemia are breast carcinoma and renal carcinoma. Those associated with acanthosis nigricans are gastric, lung, and uterine cancers. Those associated with DIC are prostatic cancers. Hypertrophic osteoarthritis may be associated with myasthenia gravis may also be associated with bronchogenic carcinoma. Peripheral neuropathies may be associated with breast carcinoma. Now, paraneoplastic syndrome is mediated through cross-reacting antibodies or the production of physiologically active factors or the interference with normal metabolic pathways. The most common tumor associated with PNS is small cell carcinoma of lung. Most common PNS is hypercalcemia, and it is caused by PTH-related proteins. Now we come to the lab diagnosis of cancer. There are various methods of lab diagnosis. These are histological methods, cytological methods, immunohistochemistry, flow cytometry, and tumor markers. Histological methods may be of two types: paraffin embedded technique and frozen section. In paraffin embedded technique, 10% formalin fixed tissue for 24 hours is used. It is processed through a tissue processor having an overnight cycle. Alcohol plus xylene. Alcohol causes dehydration and xylene causes the tissue to become transparent. It is embedded in molten paraffin wax for making tissue blocks. Now these blocks are cut into 5 sections, 3 to 4 micrometer in diameter or size, using rotatory microtome. Then afterwards they are stained with H&E staining. The frozen section is the procedure which is generally carried out when patient is undergoing surgery. In this cryostat machine is used and the tissue is sectioned. Rapid H&E or toluidine blue staining is used. Tissue is embedded in ice instead of wax, and unfixed tissue is used. Cytological methods are also of two types: exfoliative cytology and FNAC, fine needle aspiration cytology. Exfoliative cytology is the study of cells shed off into body cavities. FNAC is the study of cells by putting a fine needle into the lesion. It is done using a syringe. FNAC consists of 4 coordinated steps: palpation, aspiration, smear preparation, and microscopy. The principle on which FNAC works is the negative pressure created in the syringe by the aspiration holds the tissue against the sharp cutting edge of the needle, so that the tissue is cut by the cutting end of the needle and accumulates within the lumen of the needle or the syringe tip. It is used commonly for the assessment of readily palpable lesions, for example breast, thyroid, or lymph nodes. It can also be used for deep-seated structures, for example pancreas and pelvic lymph nodes. Immunohistochemistry is the method of analyzing and identifying cell types based on binding of antibodies to specific components of cell. Antibody which is specific for an antigen of a particular tissue is labeled with a probe, a colored marker, and is run on the tissue specimen, which is obtained from a biopsy. If the tissue has that particular antigen, then the antibody will get attached to the tissue and the labeled antibody can be seen under a microscope. Various immunostains are keratin, which is used for carcinoma, and desmin, which is used for sarcoma. Vimentin is also used for sarcoma. Flow cytometry is used to identify cellular antigens expressed by liquid tumors, those that arise from blood-forming tissues, for example B and T cell lymphomas, leukemias, and myeloid neoplasms. The advantage over immunohistochemistry is that multiple antigens are assessed simultaneously. The last lab D, the process of lab D, is tumor markers. They are biochemical indicators of the presence of a tumor. Some tumors produce or elicit the production of markers that can be measured in serum or urine or other body fluids. They may be enzymes, cell surface antigens, hormones, tumor-associated proteins, oncofetal antigens. They lack sensitivity as well as specificity because many of these products are produced by normal body cells also. A few examples include HCG, which indicates trophoblastic tumors, calcitonin, which indicates medullary carcinoma of thyroid, alpha-fetoprotein, which is a tumor marker for liver cell carcinoma, immunoglobulins for multiple myeloma, PSA, prostate specific antigen for prostatic cancer, CA125 for ovarian cancer, CA99 for colon and pancreatic cancer, and CA153 for breast carcinoma.